So hi everyone, my name is Caitlin Andrus and I'm a fourth year medical student here at the University of Ottawa. And I'm excited to be able to share with you the results of a research project that I've been working on for the past 2 years, which is entitled, Does an Elevated Troponin Ultimately Matter? An Assessment of Outcomes in Patients Presenting to the Emergency Department with Non-Cardiac Complaints. And this was completed under the supervision of cardiologist Dr. Benjamin Chow and Dr. Habiba Garuba at the University of Ottawa Heart Institute. So just to give you all a bit of background on this topic, so acute coronary syndrome, or ACS, is one of the most time-sensitive diagnoses made in the emergency department. And troponin measurement is an invaluable tool. However, its utility depends really on the clinical context, and it's highest where there's a strong pretest probability. So studies show that most troponin elevations are due to non-cardiovascular causes. However, elevated troponin has also been associated with increased morbidity and mortality, which often prompts additional investigations. And this results in lengthened stays in the emergency department, increased cardiology referrals, increased both invasive and non-invasive cardiac diagnostic testing, imaging, as well as admissions, and increased length of hospital stay for patients. And these are really sources of additional costs to the healthcare system, as well as increased anxiety and unnecessary exposure to the risk of testing for the patient. So really the purpose of our study was to compare 1-year cardiac outcomes of patients who presented to the emergency department with non-cardiac complaints and an elevated troponin between those who went on to have further cardiac evaluation versus those who did not. And really we defined cardiac outcomes as unstable angina, STEMI, NSTEMI, stroke TIA, revascularization, hospitalization for a cardiac cause, so ischemia or heart failure, or death. And in terms of our hypotheses, so we hypothesized that unrestricted or indiscriminate ordering of cardiac troponin levels in the emergency department for non-cardiac presenting complaints would lead to further unnecessary investigations for patients. And further, we felt that restricting the ordering of troponin for non-cardiac complaints to physicians in the emergency department rather than automatically at triage would reduce further unnecessary investigations. So in terms of our methods, we conducted a retrospective chart review of adult patients over the age of 18 who were assessed in the emergency department for non-cardiac complaints and were found to have a high troponin from January 1st to June 30th of 2016. So in total, 1,499 patients were analyzed and they were stratified into 3 groups. So in group 1, we had patients with no further evaluations that were done, and this included 1,131 patients. In group 2, we had patients who underwent only a cardiac consultation, and this included 81 patients. And in group 3, we had patients who underwent further cardiac diagnostic testing and/or cardiology consultation, and this included 297 patients. And then here we've just represented how those patients were stratified into these groups pictorially. So first, again, at the top here, you can see that all patients who presented to the emergency department with a positive or initial elevated troponin were included in the study. And then here on the right, you can see that any patient who had a cardiac presenting complaint, so that included anything like chest pain, palpitations, syncope, shortness of breath, or cardiac arrest, or those who received a cardiac diagnosis in the emergency department were then excluded from the study. And that left us with these non-cardiac presenting complaint patients who were then stratified into our 3 groups. And as you can see, for all 3 groups, we looked at those cardiac outcomes a year out after they initially presented to the emergency department. And then just a note here that the double asterisk for cardiac diagnostic testing in group 3, in terms of what those tests look like. So this included exercise stress ECGs that the patients went on to have, Holter monitors, coronary CT angiography, stress echoes, regular echoes, myocardial perfusion imaging, so SPECT or PET, or cardiac catheterization. And then just to continue on with our method, so data on all of these major adverse cardiac outcomes or events, so MACE, or these cardiac outcomes, as we're calling them. So again, included unstable angina, STEMI, NSTEMI, stroke TIA, revascularization, hospitalization for a cardiac cause or death. So data on all those outcomes were collected for those that occurred within a year of that patient's ED presentation. And then a Pearson's chi-squared analysis assessed for a difference, or was used to assess for a difference in proportions of the outcomes between these groups. And in terms of our results, really, we found no statistically significant difference in the proportion of patients who developed unstable angina, STEMI, NSTEMI, stroke or TIA, revascularization, cardiac hospitalization or death. So our p-value was never less than 0.00. Sorry, our p-value was never less than 0.05. And in terms of our discussion, so really the key take home from our results is that overall, in patients with an isolated elevated troponin and a non-cardiac complaint, our data showed no difference in mortality or cardiac event rates between those who had further cardiac testing and or cardiac consults and those who did not. And so really, we feel that we were able to conclude that troponin ordering should be cautiously limited to presenting complaints or preliminary diagnoses likely to have cardiovascular etiology or sequelae, or to those in whom further testing would impact management or outcomes. And further, we felt that our data supported that triage protocols should be reevaluated to limit troponin ordering in the setting of non-cardiac complaints and the potential of risks of any unnecessary tests. And we felt overall that this would ultimately improve the quality of care for patients by reducing their length of stay in the emergency department, and again, those potential risks that they're getting exposed to from unnecessary tests. So in the future, we hope to determine whether these recommendations are truly cost saving, and we also hope to classify what level of troponin elevation is ultimately more likely to predict a future cardiac outcome. And overall, we hope these findings will inform changes that will improve the quality of patient care by reducing their length of stay in hospital. So thank you for listening, and I'll now take any questions.
This is Dr. Kelly Branch, and it is my pleasure as part of the University of Washington and the Medic1 Foundation to share with you information regarding the early head-to-pelvis computed tomography in out-of-hospital circulatory arrest without obvious etiology. These are my disclosures, none of which are relevant today. So why CT for sudden death survivors? Well, out-of-hospital circulatory arrest, or OHCA, is actually quite common, occurring in 140 per 100,000 patients in the United States. Sudden cardiac death is common in ventricular tachycardia and ventricular fibrillation, occurring up to 70% of the time, although sudden non-cardiac death can range from 30 to 60% depending on the presenting rhythm. In patients without obvious cause for OHCA, we term these patients idiopathic OHCA. As we all know, post-resuscitation, patients arrive unconscious, intubated, and oftentimes with scant history, and so we rely on further information such as imaging to help us as far as making decisions. However, there are few data on the diagnostic accuracy of imaging in patients, and this includes echocardiography, CT, and ultrasound. And guidelines as such are largely equivocal on the use of imaging after OHCA. To address this, the CT first, or the CT feasibility in resuscitated patients for sudden death triage, was designed, and this was the prospective use of a sudden death CT in patients resuscitated after OHCA. The primary outcomes were the feasibility of this, as well as the diagnostic yield and the ability to detect time-critical diagnoses. The safety outcomes were renal dysfunction because we are using iodinated contrast, as well as erroneous CT findings that could lead to further evaluation and inappropriate evaluation. The sudden death CT protocol used two very contemporary and advanced CT scanners and consists of the following: a non-contrast head CT, followed by an ECG-gated chest, which included imaging 80 to 100% of the cardiac cycle, followed by a spiral abdomen and pelvis CTA, which was non-gated. Because we were not optimized to do coronaries that include beta blockers and nitroglycerin, coronary and cardiac findings were initially blinded, although all other CT findings were available to the providers. The final cause for the OHCA event was determined by adjudication by two physicians, and this was considered the gold standard. In the 104 patients that were enrolled, you can see the baseline characteristics here. This is a relatively young group with an age of approximately 56, and you can see the various baseline medical histories. What I'd like to bring your attention to is the initial rhythms, which included a fairly reasonable distribution of rhythms, including VFVT and asystole, but most of the patients had pulseless electrical activity prior to scanning. Here are the primary outcomes, and in those patients that were diagnosable by SDCT, as far as the OHCA cause, 39% of those patients actually had some type of diagnosis that was could be identifiable by SDCT. Of these, 95% were actually diagnosed by SDCT, and this was the so-called diagnostic yield, or the primary outcome. In addition, those patients with time-critical diagnoses were detected by CT at 98% yield, 43 of 44, and these also included critical resuscitation complications. To become a little more granular, you can see here that the SDCT diagnosis of OHCA cause included acute coronary syndrome, pneumonia, hemorrhagic stroke, pulmonary embolism, abdominal catastrophe, as well as heart failure, with only 2 misdiagnoses, one of which was acute coronary syndrome, with a limited number of images for coronary analysis, as well as heart failure, which had one patient with a normal LV size but decreased ejection fraction who was not recognized as heart failure per se. In those patients with the time-critical diagnosis, you can see 98% yield, and you can see many of the critical diagnoses were shared with those adjudicated diagnoses, but also had 39% of resuscitation complications, which included lacerations and hemorrhages, pneumothoraces, and other lacerations such as pulmonary laceration and vascular access hemorrhage. However, it's important to also talk about the safety of the CT first. An acute kidney injury was identified in 25% of patients, but this is rather similar to other reports in OHCA. Approximately only one patient required renal replacement therapy, and it was interesting, there was no difference in creatinine with contrast from CT as well as invasive coronary angiography in these patients. More importantly, there were no erroneous CT diagnoses that actually altered therapy, and only one complication of contrast extravasation during sudden death CT. So in summary, CT first sudden death CT identified 39% of all causes of OHCA, and of those, 95% of patients with potentially visualizable by SDCT were actually identified by SDCT. This expedited diagnosis in time-critical pathologies in 98% of patients, including resuscitation complications, and early SDCT scanning appears to be safe, can expedite the diagnosis of potential causes, and can meaningfully change clinical management after idiopathic OHCA. These data are summarized now in the Academic Emergency Medicine released in March of this year, and I'd like to thank my colleagues as well as patients and all of those that supported these endeavors, including the Medic One Foundation. Thank you very much.
Hello everyone, this is Zubair Rafiq from Baylor College of Medicine, and I'm going to be talking about standardizing hyperkalemia treatment, the PLATINUM study. I'm presenting this on behalf of the PLATINUM investigators. Now, PLATINUM stands for Paternal Utility as an Adjunct Treatment in Patients Needing Urgent Hyperkalemia Management. That's a whole bunch of words. I'm only going to say PLATINUM from now on. Now, this study is funded by V4 Pharma, the makers of Paternal. I'm the national PI, and since I work on hyperkalemia, I'm a consultant for both V4 Pharma and AstraZeneca. A brief background on hyperkalemia. We all know hyperkalemia. Some of us see it more, some of us less. Depends on where we work. We know it's potentially life-threatening. The prevalence is 3 to 9%, depends on the study you look at, 3% by a US study, up to 9% in a Swiss study. But what's more important is it's growing. And that's because hypertension, diabetes, all these are on the rise, and so hyperkalemia is growing. Now, on top of that, the ED standard of care is non-existent. That's because the drugs we use are off-label uses. They have small studies, it's anecdotal experience, handed down knowledge that's not evidence-based. Now, in the absence of a standard, what we have is a wide practice variability. And that was shown by Frank Peacock in a study called REVEAL ED in 2018. REVEAL ED is an observational study. It enrolled 200 plus patients from 30 different US emergency departments. And what it showed was 200 patients were treated in 144 different ways of permutations, combinations of the different drugs that were available. Now that's the total opposite of a standardized way of treating patients. And not only is that bad for patients, but it's also poses a challenge when you're trying to understand or study hyperkalemia because the control arm is so variable. So having those in mind, we had an overarching objective of standardizing hyperkalemia treatment. So that's one objective. And the second objective was to define a new endpoint for hyperkalemia treatment. And we'll talk more about that in a bit. So the study-specific goals were efficacy and safety of patiromer in the emergency department. And that's done by this design of a multi-center randomized double-blinded placebo-controlled trial. Now, 300 patients with hyperkalemia are enrolled in a one-to-one fashion, randomized in a one-to-one fashion to patiromer plus standard combination therapy versus placebo plus standard combination therapy. And then potassium is recorded at baseline 2, 4, 6, 8 hours or at end of ED. Now at end of ED, when subjects go home, they're given one more dose of either patiromer or placebo and brought back to check their potassium level to see if patiromer has a sustained effect after discharge. And then the first part of the study is to see if patiromer lowers potassium in the emergency department. Okay. The inclusion exclusion criteria are pretty simple. If you're an adult with hyperkalemia, you're included. If you're sick, significant arrhythmia or hemodynamic instability, you're excluded. If you overdosed on potassium, probably not a good candidate. If you have bowel obstruction, you cannot take PO meds, you're out. If you're already on a K binder, then you're excluded. And then if you cannot be in the study for long enough, up to 6 hours, then you are excluded. And then there are some generic exclusion criteria if you're allergic or if you're pregnant or breastfeeding or not able to take the drug, then you're out. All right, so this is the part for standardizing hyperkalemia treatment. We looked at all the available data, looking at surveys, lit reviews, guidelines, and we decided that a two-drug regimen, a combination therapy, is better than a one-drug deal. And we also wanted to lower the amount of insulin we give because high insulin doses causes more hypoglycemia and also has a sustained effect in CKD and ESRD patients. So we wanted to use 5 units of insulin together with dextrose and then supplement that with albuterol. Together, insulin and albuterol will do a better job in lowering potassium and also have better side effect profile. So that's our standard combination therapy. And then we have the net clinical benefit, which is a new endpoint we are defining. Now, the endpoint cannot be I fixed it, because if that's the case, just lowering potassium, then all those 144 ways worked. And so we wanted to bring in the concept of effort. How much effort does it take to lower the potassium? And net clinical benefit captures those two ideas. So imagine a scenario where a nurse has to stand and give insulin and then check glucose level and potassium level every 2 to 4 hours or every 30 minutes, whatever the protocol is, versus you give one combination therapy and you are done, right? Obviously, the latter one is better. And that captures the fact that, how much effort does it take to lower the potassium? So net clinical benefit will capture both potassium lowering effect as well as how easy is it to lower the potassium or how much effort is it taking to lower the potassium. So in conclusion, the PLATINUM study has the potential to standardize hyperkalemia treatment in the emergency department. And that's by analyzing the control arm. We can tell you if the standard combination therapy, how efficacious that is, what are the adverse events, the retreatment regimen, and all those points. The PLATINUM study also will define a new endpoint, and that will be used for future hyperkalemia studies. And then lastly, we will evaluate the efficacy of patiromer in the ED and after discharge. So does patiromer work in the emergency department, and does it have a sustained effect 24 hours out? Okay, study update. We were affected by COVID like everybody else. Our study took a back seat. So even though we started last year, we only have 10 sites that are active. We enrolled 10% patients, but the enrollment has picked up. And so we expect to have our study completed in 12 months. Questions?
Hello everyone, thank you for joining. My name is Rebecca Martin and I'll be presenting emergency department visits for pulmonary embolism and deep venous thrombosis after the arrival of COVID-19. My co-authors and I have no disclosures. Some background: COVID-19 infection has been shown to be associated with increased numbers of PE and DVT. COVID-19 arrived in the New York City area in early March 2020. Therefore, our study, we hypothesized that the number of ED patients diagnosed with PEs and DVTs increased after the arrival of COVID-19. Our study used a retrospective cohort of data from 28 hospital EDs within 150 miles of New York City, including teaching and non-teaching hospitals in rural, suburban, and urban areas, with an annual ED volume ranging between 12,000 and 122,000 patients. We looked at ED patients from March through November in 2019 and 2020. We looked at the difference in number of patients diagnosed with PEs and DVTs from 2019 to 2020 using ICD codes. We used chi-square to test for statistical significance with an alpha set at 0.025 using the Bonferroni correction for multiple comparisons. Our results can be seen on the following table. As we can see, the total number of visits between March through November 2019 was about 1,161,000, and same time period in 2020, it decreased to about 814,000. Number of PE cases decreased from 1,349 to 1,180. The number of DVT cases decreased from 1,977 to 1,575. Median age was about the same at 62, and percent female was also approximately the same at 52% in 2019 and 50% in 2020. We can see the results show a 30% decrease in total visits from 2019 to 2020. Visits for PE and DVT decreased from 2019 to 2020 by 20% and 13% respectively. Therefore, we concluded that, contrary to our hypothesis, after the arrival of COVID-19 in the New York City area, visits for PEs and DVTs did not actually increase. We suspect possible explanations are that the decrease in ED visits in 2020 due to public fears of exposure to COVID-19 infection during hospital visits led patients with these conditions to go underdiagnosed. Also, special challenges in performing tests for PE and DVT diagnosis on patients on investigation for COVID, especially early on in the pandemic, could have led to underdiagnosing as well. Lastly, I'd like to thank my co-authors, Dr. John Allegra and Dr. Barnett Askin from Morristown Medical Center, and thank you all for listening.
Hello and welcome to this SAEM 2021 presentation entitled Pulmonary Edema Severity by Lung Ultrasound Predicts Central Apnea in Acute Heart Failure. I'm Nicholas Harrison and these are my co-authors. First, a little bit of background. Central sleep apnea is recognized to be common in heart failure and specifically the Cheyne-Stokes respiration subtype. This is a distinct type of disordered breathing characterized by a cyclical pattern of tachypnea and hyperpnea followed by apnea and bradypnea. This pattern is associated with adverse clinical outcomes in heart failure, but it's rarely recognized. The reasons are that central sleep apnea symptoms tend to overlap with the symptoms of heart failure itself. Central apnea lacks the obvious signs such as snoring that are characteristic of obstructive sleep apnea, and sleep studies are rarely done on inpatients outside of a research setting. Because of this, the etiology and ideal treatment of central apnea in acute heart failure is unknown. However, it has been theorized based on animal studies that pulmonary edema directly causes central apnea. Our research question in this study was to test if this physiologic hypothesis holds up in humans. This would be significant if shown to be true because the undertreatment of pulmonary edema in acute heart failure is known to be common. Moreover, it's been demonstrated that residual B lines on lung ultrasound at hospital discharge are associated with a 5 times higher rate of mortality and rehospitalization. Thus, if pulmonary edema does have a dynamic and treatment-responsive relationship with central apnea, it could mean that these observed adverse outcomes are mediated by unrecognized central apnea. Moreover, it could point towards the utility of lung ultrasound-guided decongestive therapy as a therapeutic paradigm. To test our hypothesis, we performed a substudy of an ongoing prospective multicenter observational cohort. Currently, this substudy includes 36 patients. Patients received echocardiograms, 10-point long ultrasounds, and 3-minute IVC ultrasounds for respiratory pattern and effort, rated into one of 3 ordinal categories: normal breathing, periodic Cheyne-Stokes breathing with less than 10-second apnea, and Cheyne-Stokes breathing with greater than 10-second apnea. The 10-second cutoff comes from adaptation of the American Academy of Sleep Medicine's guidelines. Timing of exams, including an ED arrival ultrasound, which was before or no more than 1 hour after the first treatment with diuresis, IV or sublingual nitro, or positive pressure ventilation. After that, patients received follow-ups through the end of their hospital discharge at 24 hours, 72 hours, and 7 days, or stopped at the time when they were discharged from the hospital. Of note, we allowed patients to be awake during the scan because critical to the underlying physiologic hypothesis is the idea that hyperventilation should be able to cause even awake patients to show signs of central apnea. The statistical analysis was a random effects regression model in which we observed the dynamic correlation of respiratory pattern versus 0 to 200 lung ultrasound score as patients progressed through their AHF hospital treatment. We adjusted for variables including time, age, gender, BMI, positive pressure ventilation use, sleep apnea history, and COPD history. Here you can see characteristic M-mode IVC tracings for each of the 3 respiratory patterns. Overall, only 47% of exams had normal respiration. 28% showed a periodic breathing pattern, and 25% of awake patients showed a Cheyne-Stokes respiration pattern with at least 10-second apneas. As expected, patients generally had a downward trend in lung ultrasound score throughout their hospitalization as they were treated for their heart failure. However, it should be noted that quite a few patients still had significant residual pulmonary edema by the time they were discharged, and some patients had a much flatter trajectory of their lung ultrasound score over time. There was a significant association between breathing pattern and pulmonary edema, with those with worse apnea showing more pulmonary edema and those with normal breathing showing less pulmonary edema. Additionally, the changes in pulmonary edema between 2 time points were associated with the directionality and degree of changes in breathing pattern. Those who had improvement in their breathing pattern between 2 time points had a much greater decrease in pulmonary edema. Those who had a worsening breathing pattern had an increase in pulmonary edema. There was also a significant association between worsening of breathing pattern and RV systolic function. The tricuspid annular plane systolic excursion, or TAPSE, decreased from patients who had normal breathing through periodic breathing and Cheyne-Stokes respiration. There was a less clear and inconsistent association with LV systolic function. In the regression model, adjusting for time, age, gender, BMI, positive pressure ventilation use, OSA, and COPD history, we noted a significant association between worsening breathing pattern and increasing pulmonary edema by lung ultrasound score. Every 1-step worsening of breathing pattern was associated with a 33.7 increase in lung ultrasound score. In a secondary analysis, we compared RV systolic function to breathing pattern adjusted for time. This too showed a dynamic and time-independent association with a decrease in TAPSE of 2.76 for every 1-step worsening in breathing. Overall, our study shows first-in-man evidence of a dynamic and time-independent association between pulmonary edema severity and central apnea and acute heart failure. We were also able to show that central apnea appears to be common in AHF even in awake patients and even without a chronic sleep apnea history. An analysis of breathing patterns versus 30-day clinical outcomes is pending completion of the parent study. But in this study, we do show a novel association between acute and dynamic RV dysfunction on echo and apnea and periodic breathing. There are important implications for future clinical science, including a potential role for lung ultrasound-guided decongestion as a direct treatment of CSA-CSR. This would need to be tested in a future clinical trial, but has extreme promise going forward. To conclude, we look forward for any questions that you may have in this forum, or if you would prefer, reach out via email. Thank you for your time. Have a nice day.
Good morning, everyone. My name is Robbie Waller, and I am a PGY3 emergency medicine resident at Penn State Milton S. Hershey Medical Center in Hershey, Pennsylvania. Today, I'll be presenting on behalf of my colleagues on the evaluation of provider assessment of clinical history when using the HEART score. None of the authors have any financial conflicts of interest to disclose. Chest pain is one of the most common chief complaints in the emergency department, Quickly differentiating between acute coronary syndrome and other causes of chest pain is vital for providers in any setting, but especially in the ED. In order to do this, risk stratification tools such as the heart score were developed. This particular tool was created in 2008 and has been externally validated on several occasions through 2017. This prognosticator assists with the determination of a patient's risk of major adverse cardiac events, or MACE, within 6 weeks by assessing 5 different categories, namely history, EKG, age, risk factors, and troponin level. It is graded on a scale of 0 to 10, with 0 to 3 correlating with a 2.5% risk of MACE, a score of 4 to 6 with a 20.3% risk of MACE, and a score of greater than 7 with 72.7% risk of MACE. As a result, scores greater than 4 are often placed in observation units or admitted to the hospital for further testing. The difficulty in using the heart score is in the subjectivity of the history portion. The initial heart score did indeed provide guidelines for how a provider is to categorize a history as slightly, moderately, or highly suspicious, and this was to be done based on chest pain characteristics alone. However, providers tend to be influenced by other already accounted for categories such as age or risk factors when determining the historical suspicion. Not properly categorizing the historical portion of the heart score may falsely elevate the overall risk estimation, potentially leading to an increased resource utilization, such as stress tests, catheterization, consults, or inpatient beds, increased healthcare costs, and even potentially invasive testing. Our question was, do cardiac risk factors influence a provider's assessment in the subjective historical portion of the heart score? Risk factors assessed included patient sex, age, concerning past medical history, concerning appearance, prior negative cardiac workup, ethnicity, and socioeconomic status. Our study design consisted of a survey sent to both physician and non-physician providers in EM and cardiology across the US that was distributed via SurveyMonkey. The survey was randomized using SurveyMonkey to provide participants with one of 2 possible versions of a clinical vignette that isolated one of the above-mentioned focal points. Here's an example. In these vignettes, the only differences are those accounted for by risk factor category, such as hypertension instead of coronary artery disease, status post-percutaneous coronary intervention, or smoking history, while the actual character of the chest pain remains the same. As part of the survey, we collected demographic information, including age, sex, specialty, number of years in practice, practice setting, community versus academic, if they use the heart score, and if they find it useful. We received a total of 1,330 responses. Most of the respondents were EM physicians and community practitioners. Also, the majority were attendings and regular users of the heart score. The mean number of years in practice was 17. Overall, both services tend to overestimate the historical portion if the patient had a history of coronary artery disease, status post-percutaneous coronary intervention, versus just hypertension, despite the exact same chest pain description. As shown here, this was statistically significant. For clarity, the correct suspicion score is highlighted in red. Inflated scores also occurred with significantly distressed appearance versus mildly distressed appearance. Similar overestimations were seen with older versus younger patients, and with lower socioeconomic status. On the other hand, providers were more likely to underestimate if they had a knowledge of patients having had a previous negative stress test. Lastly, but not statistically significant, there were marginal trends for providers to overestimate for males versus females, and a similar trend was noted for Caucasians versus African Americans. When compared head-to-head, EM tended to overestimate and cardiology leaned toward underestimation. Statistical significance was found in the following areas: patients with a history of hypertension, differences in sex, mildly distressed appearance, Caucasians, and socioeconomic status, as seen here. The upward arrow indicates overestimation, the equal sign indicates accurately estimated, and the downward arrow indicates underestimation. Using some of the other demographic data collected, we were then able to look for differences between academic and community providers, attendings and learners, physicians and non-physicians, years in clinical experience, and males versus females in their assessments of history using the heart score, as seen here. Broadly speaking, community providers, attendings, those with more experience, and female providers tended to overestimate a patient's risk, while residents/fellows, non-physicians, and those with less experience tended to underestimate. Greater accuracy was seen by academic providers, physicians, and males. There was little difference in accuracy between attendings and learners and between varying years of experience. Summarize briefly, both EM and cardiology providers overestimated for classic prognosticators, but EM tended to do so more than cardiology. The latter is also more accurate in their assessment. While it stands to reason that inflated cardiac suspicion based on the history leads to an elevated heart score and increased resource utilization, our study did not specifically evaluate for this, and therefore further studies are needed to determine if such an effect is truly present. We believe that more education in proper usage of the heart score, specifically in assessment of cardiac suspicion based on the history, can potentially help to decrease unnecessary resource utilization and unneeded expenditure on cardiac workup.
Hello everyone, and welcome to my presentation on evaluation of high sensitivity troponin I in a 0-1 hour algorithm for the acute diagnosis of myocardial injury. So the background of this project is that current recommendations for high sensitivity troponin assays include an initial troponin blood draw as well as a repeat at 1 and 3 hours. The European Society of Cardiology has a 0-1 hour algorithm for rule out and rule in of MI as soon as 1 hour after insult, but this has been verified mainly in Europe and not something widely adopted here. It's also important to note that different cutoffs exist based on the type of troponin and manufacturer. UF Health was the first hospital system to implement the Beckman-Coulter high sensitivity troponin I assay in the nation, so safety and evaluation and verification is necessary on a large scale. Our study objective is to evaluate the diagnostic performance of this algorithm for NSTEMI at UF Health ED. A sub-analysis of a single initial troponin value for rule out of it is for rule out if it is below the limit of quantification. This is and down here below is an overview of the algorithm for rule out, observation, and rule in. Now on to the methods. We conducted a quality improvement IRB approved retrospective cohort study for all UF Health ED visits from May 20th, 2019 to September 2019. That had a high sensitivity cardiac troponin I that was measured, and this was a total of about 1,500 patients. Inclusion criteria for patients was that they had symptoms suggestive of acute coronary syndrome, as well as having a 0 and 1 hour blood draw for troponin soon after ED arrival. Exclusion criteria was if the patient had a STEMI or left against medical advice. The outcome measures that we looked at was a confirmed NSTEMI at the ED visit, and we used that to determine rule out safety measured by the negative predictive value, rule in accuracy via the positive predictive value, and the overall efficacy of our rapid algorithm, which looked at the combined proportions within the rule in and rule out groups as compared to the more unknown observation category. Additionally, part of our sub-analysis was looking at those with an initial troponin that was less than 6 nanograms per liter, which was the limit of quantification set by the manufacturers that we used for our troponin assay. And for those patients, we looked at the index AMI rates as well as cardiac-related deaths within 30 days of visit. Looking at the results of our study, amongst the 1,673 NSTEMI suspected patients who met inclusion criteria, the prevalence of NSTEMI was 6% based on a total of 93 patients. Looking at our 0-1 hour algorithm here below, the negative predictive value, which indicates our rule out safety, was 99.6%, as 5 patients in that rule out category had an NSTEMI. And alternatively, we can look on the right in the rule in category, which had a positive predictive value of 70.3%, indicating rule in accuracy, as the majority of patients who were in the rule in category did have an NSTEMI. The last outcome that I'm going to talk about here that we were looking at is the overall efficacy of the algorithm, where 83 and 6%, so a total of 89% of patients were placed into either the rule out or rule in category, demonstrating a high efficacy of the knowing which category the patient would be in as opposed to the unknown observation group. Now on to the sub-analysis portion where we're looking at the lower limit of quantification. So here's an expanded rule out category from our diagram, and we're looking at 0 hours, the initial troponin being less than 6 nanograms per liter. So there were a total of 963 patients which met this criteria. And of those, there was a there was 2 who had an NSTEMI, as compared to a 99.79% negative predictive value for NSTEMI. And the 30-day cardiovascular death rate was 0 for that. So now on to conclusions and future directions. In conclusion, here's just a little recap of the data that was described on the previous slides. And so overall, the ESC 01-hour algorithm for high sensitivity troponin is a safe and effective tool for ruling out NSTEMI at UF Health ED. Therefore, we recommend further consideration for utilization of said algorithm within the ECS diagnostic pathway to allow for safe discharge of ED patients. And for future directions, this was a limited 4-month data set, and we are currently expanding it to include up to January 2021. We'd also like to measure other cardiac-related events to understand outcomes like cardiovascular deaths, MACE, and revascularization rates. Another interesting finding is that compared to European ED populations, UF has a greater rule-out proportion of 82% compared to their 44%. So we may investigate why this is the case. Could it be that poor access to primary care in the US could be contributing to that? It's possible, and so that's something that we are exploring. Thank you.
Hello, my name is Richard Nowak. I'm from Henry Ford Health System in Detroit. My presentation is Indeterminate Zone High Sensitivity Troponin I levels in a rapid AMI assessment algorithm, patient dispositions and outcomes. My disclosures, besides liking fast cars, are that I've had research grants and consulting with the makers of high sensitivity troponin assays, and today in particular, the study I'm going to talk about has been funded by Siemens Healthcare. We published in the Annals of Emergency Medicine last year the performance of a Siemens high sensitivity cardiac troponin assay in a 1-hour rule-in, rule-out algorithm using cut points that were determined by a European patient population to see if there was harmonization between Europe and the US in this regard. The high US trial had 29 sites enrolling, academic, non-academic, I think a good mixture of the US population. We enrolled anyone that the treating physician drew a troponin on, thinking that they might have an AMI. There were no exclusion criteria. People were managed by the ED doc. Bloods were drawn, frozen, and were later batch analyzed using the Siemens Telica IM high sensitivity cardiac troponin assay. NSTEMI was determined by an independent panel using all 30-day data available, which included the contemporary troponin measurements at every particular institution. Patients were followed for 30 days to see how they did. These are the main results of that Annals paper. You could rule out a lot of people for AMI with very high negative predictive value. If they had very low values, the values were a lot higher. You could rule in people. Number wasn't nearly as big, and the positive predictive value I don't think is adequate. Then there's all those people that didn't rule out or rule in, and what the heck do you do with them? We had looked at and published this year on what happened to the people who ruled out. We say they ruled out, but what really did happen to them? Well, it turns out that using the contemporary assays and clinical evaluations, ED docs placed about 40% of them in observation or admitted them. And in that paper, we suggest that you really didn't need to. They all could have been managed on an outpatient basis. So what actually happened to those that were in the indeterminate and continued evaluations, observations? So turns out that of 763 that we could evaluate, one third approximately were sent home. The other 2/3 were admitted or placed in observation for further evaluation. The question was, who are these people and what happened to them? Well, first of all, you can say that in these sites, the decision to send this patient population either home or for further evaluation in the hospital, the numbers and percentages varied a lot based, I guess, on local thinking and algorithms and thoughts, etc. We tried looking at determining cut points within that indeterminate range to see if that would help you determine who could safely go home or who would need to stay, and we, like everyone else, could not do that. We look now at the baseline characteristics of these two groups of people. It does turn out that there are a lot of comorbidities and cardiac risk factors in both groups, more in the OBS admission group, but certainly a lot in those that were sent home. It turns out that of those people we sent home who were in the indeterminate range, 2.9% would have been adjudicated as an AMI. And we believe that's because they were early presenters, and so serial levels of troponin would have made the diagnosis. Those that were admitted around a lot more, as you can see, had a diagnosis of AMI. There were 5 variables when you look at a multivariate analysis: age, hypertension, renal insufficiency, failure, abnormal ECG, and previous revascularization, that actually were things that predicted the ER docs would place someone in the hospital when they were in this indeterminate zone. It does turn out that if you follow them, patients for 30 days, only one of those that ER docs sent home had an AMI at day 26, quite a ways out from ED disposition. So what are our conclusions? Our conclusions are that the correct disposition for patients not ruling in or ruling out using the 0-1 hour high sensitivity cardiac troponin algorithm does remain unclear. Using contemporary troponin values and clinical evaluations, we did in this trial have 231 of these patients go home. When we placed them in the evaluation zone, we realized we had made very good decisions because there were only 2 of these that were sent home that would have been re-adjudicated as an acute AMI, and I think that's because they were very early presenters. There was only 1 patient that had an AMI 26 days after ED discharge. Nobody died within that time period. So I do think that its physician's general gestalt is very good at determining who can go home and who doesn't. That includes talking to the patient, evaluating their history, evaluating them. Well, I think ER docs are very good at that. And so further studies are required to validate our results and our analyses from the high US trial database. I'm going to stop now. If there's any questions, this is a painting I'm going to share with you that I just happen to like quite a bit.
Hi, my name is Alex Talassi, and I'm a student nurse with the University of Pittsburgh. Today, I'll be speaking about associations between emergency department presentation and delay in seeking care for suspected acute coronary syndrome. Dr. Clifton Calloway has NIH funding. Myself and my other co-authors have no conflict of interest to disclose. Chest pain is the second leading cause of emergency department visits in the United States. In patients with acute coronary syndrome, rapid reperfusion decreases mortality and infarct size. Revascularization is the standard of care for ACS events, either by cardiac catheterization or fibrinolytic therapy. These treatments are time sensitive, with a gold standard door to balloon time of 90 minutes and a door to needle or fibrinolytic administration time of 60 minutes. Although fibrinolytics are currently being used up to 12 hours after coronary event in patients without contraindications. Delay of initial presentation to the emergency department affects time to treatment, and nurses need to quickly recognize the characteristics of ACS to make it for that lost time and administer time-sensitive revascularization treatment. In our study, pre-hospital delay is defined as time from symptom onset to ED arrival per patient report. This data was extracted from the electronic health record and documented as either the patient's stated time of symptom onset, or we calculated it using our clinical judgment. With a large population of potential ACS patients requiring rapid intervention, the aim of this study was to identify characteristics of patients with a suspected coronary event at initial presentation to the emergency department that are associated with pre-hospital delay greater than 12 hours to guide more efficient triage and promote timely intervention. Pre-hospital delay remains excessive, as more than half of our patients delayed more than 12 hours to ED presentation. So it is important that ED nurses are able to accurately recognize patient characteristics upon presentation associated with pre-hospital delay, so they may more efficiently triage and administer time-sensitive treatments to patients. This was a secondary analysis of a retrospective observational cohort study of adult ED patients with a suspected coronary event from 17 different EDs in the Pittsburgh area in 2018. Data was manually extracted from the electronic health record at the initial patient encounter during triage and used to build a multivariable binary regression model that considered patient demographics, past medical history, and characteristics upon ED presentation, including initial vital signs, chief complaints, and automatic electrocardiogram results. We performed a descriptive analysis of each variable. Continuous variables were presented as means and standard deviations and tested with a student t-test or a Mann-Whitney U-test. Categorical variables were presented as percentages and tested with chi-square. Predictors of pre-hospital delay at p is less than 0.1 in a univariable logistic regression were entered in a multivariable logistic regression model with backward selection. The significance level was 0.05 for two-sided hypothesis testing. Adjusted odds ratios with 95% confidence intervals and p-values are reported for the final model. Due to the effective age on clinical presentation of patients with ACS, we controlled for age in the final model. Our final sample included 1,201 patients with a mean age of 64 years. 46% were female and 10% were Black. In the end, 51% of our patients experienced delay greater than 12 hours from time of symptom onset to ED arrival. This is clinically important to note that more than half of our patients arrived greater than 12 hours from time of symptom onset because they are at risk for missing the window for time-sensitive reperfusion therapy. This is our final data output table. Variables associated with delay greater than 12 hours were history of cardiomyopathy with an odds ratio of 8.222, chief complaints of shortness of breath, cough, and nausea and vomiting with odds ratios of 5.594, 3.176, and 3.682 respectively. Variables associated with a delay less than 12 hours were radiating chest pain, chest tightness, chest pressure, and shoulder pain with odds ratios of 0.289, 0.287, 0.163, and 0.242 respectively. Sinus tachycardia on initial ECG was also associated with a delay less than 12 hours with an odds ratio of 0.211. Sinus bradycardia, atrial flutter, and T abnormalities on initial ECG made it into the model, but were not significant for the final model. The same is true of a chief complaint of vomiting, a history of cabbage, and a history of renal disease. More than 50% of our patients delayed more than 12 hours before arriving at the ED, reducing opportunities for rapid reperfusion. Longer delay may be partially explained by symptoms that are consistent with chronic heart failure, such as shortness of breath or cough, that were found to have a significant association with delay longer than 12 hours. Shorter delay may be attributed to symptoms associated with myocardial infarction and thus known to the public, such as radiating chest pain, chest tightness, and chest pressure. Patients may recognize the hallmark signs of myocardial infarction, thereby reducing delay. More nonspecific or heart failure-like symptoms may be associated with longer delay because they have a more gradual onset or may be attributed to existing chronic disease, such as cardiomyopathy, which was significant for delay greater than 12 hours. The clinical implications of these associations are that patients with existing conditions, particularly heart failure, who are at increased risk for ACS, should be counseled to seek care rapidly and not delay further. It is important for nurses to be able to recognize these characteristics associated with pre-hospital delay in patients with suspected ACS at triage to avoid further delaying time-sensitive reperfusion. These associations may be used to guide emergency department nurses in accurately assessing a patient's delay in seeking care and using that to more effectively triage patients and guide subsequent time-sensitive treatment choice. Nurses need to distinguish those who may need to be evaluated earlier to prevent further system delay, because the ultimate goal is to get these patients to the hospital sooner or avoid other delays once they get there.
Hello, my name is Michael Zwank. Thanks for stopping by this abstract entitled Severity of Diagnosis Among Emergency Department Patients with Chest Pain After Calling a Nurse Line. This was conducted with a couple residents and a statistician. It has subsequently been published in the American Journal of Emergency Medicine. This was inspired by a story that I had experienced quite often, as well as a number of colleagues. Basically, when you are evaluating a patient and ask them what brought them in, they would frequently tell me, I wouldn't be here except that I called the nurse line and they told me to come in. The objective of this study was specifically looking at patients who presented to the emergency department with chest pain, who called a nurse line or didn't call a nurse line, to see if there were differences between these patients, and most importantly for us, to see if there was differences in the severity of the cause of the pain. This was a case-controlled chart review study that we conducted through the electronic medical record. It was an automated data pull. Basically, cases were patients that called the nurse line, and controls were matched for age and sex and did not call the nurse line before coming in. These were all patients who presented with a chief complaint of chest pain. We collected data including demographics, comorbidities, ED orders and interventions, diagnosis, and disposition of these patients. The primary objective was looking at the severity of diagnosis, and this was determined by investigators. We had 2 investigators that went through all diagnoses and determined if they were severe or not. If there was disagreement between these two, a third investigator would step in. Results, we included 350 total patients. 175 called the nurse line and 175 didn't. The mean age was 58 years old. You can see the range there. 53.7% were female, and there was no big difference between races between the groups. Patients were more likely to go to the emergency department without calling the care line if they had comorbidities. Specific comorbidities that we detected differences in were coronary artery disease, thromboembolism, and hyperlipidemia. 36 patients had a serious diagnosis related to their chest pain. These included cardiac causes such as STEMI, AFib, and SVT, as well as pulmonary causes such as pulmonary embolism, pneumothorax, and pneumonia. And there were a couple intra-abdominal diagnoses, including biliary colic and pancreatitis, among others. There was no difference between the two groups. 16 patients with a serious diagnosis had called the nurse line and 20 did not. 73% of patients had a non-specific cause of their pain, 12% had a non-serious cause of their pain, and 4.3% had an unrelated diagnosis. There were no differences in ED workup of the two groups. 90% of the patients had a troponin ordered, and 15% had a D-dimer ordered. 117 patients, which was 33%, were admitted, and 5 patients underwent cardiac catheterization. There was no difference in hospital admission between the two groups, as you can see here. Conclusions, basically, we were a little bit surprised. We found no differences between the groups. We really had hypothesized that patients who called the care line would end up having less serious diagnoses. And the thinking behind this was that if a patient had a serious cause of their chest pain, their intuition would drive them to come to the emergency department without needing advice from a phone call. But this was not the case. Interestingly, patients who presented to the emergency department without calling the nurse line had more comorbidities. Our thinking of this was that patients who had interacted with the health system before knew that if they called the nurse line, they would probably be directed to come to the emergency department. And so our thinking was that these patients chose to come directly on their own. The limitations of the study, this was not a particularly large number of patients, and it was a single tertiary care hospital. As such, this might not be representative of the general population that comes to the emergency department, but the results were certainly informative. Thanks for stopping by and listening to this presentation.
Good morning. My name is Haney Kutab, and I'm a physician at the University of Wisconsin. I'm excited to share with you today our research group's work, which looks at the impact of fluid resuscitation, dosing, and timing on sepsis mortality. We have no conflicts of interest to disclose. While most can agree on the importance of the early identification of sepsis and the initiation of antibiotics, the use of IV fluids remains controversial. The current guidelines from the Surviving Sepsis campaign includes the initiation of a 30 ml per kg amount by 1 hour and to be completed within 3 hours. CMS has a similar recommendation, but with no guidance on the initiation of fluids, but to rather complete the 30 ml per kg amount by that 3-hour time mark. It's important to note that these guidelines are specific to patients with sepsis-induced hypoperfusion or a lactic acid value greater than 4.0. The evidence surrounding these guidelines is scarce, and what does exist is considered to be low quality and controversial. So our group aimed and is interested in exploring the impact of fluid timing and dosing in patients with sepsis, and whether or not IV fluids early in disease course could be beneficial to patients. In 2019, our group evaluated this question in a little bit more detail. In this study, our findings suggested an increase in mortality for failing to reach the 30 ml per kg amount at 3 hours, even after adjusting for confounders. We also attempted to evaluate a dose effect and found that the volume of IV fluids at 3 hours did appear to impact mortality, with a plateau effect seen around the 30 to 40 ml per kg amount. Given all of the changes in the recommendations and the controversy that still exists regarding these time points, our group aimed to perform a secondary analysis of our cohort of patients, looking at the questions surrounding timing and dosing a little bit more clearly. This was a secondary analysis of roughly 1,000 patients with severe sepsis and septic shock by sepsis 2 criteria. Patients were selected by ICD-9 and 10 codes at hospital discharge, but we also flagged all cases in the ED where there were orders for blood or urine cultures or broad-spectrum antibiotics, and reviewed and included those patients if appropriate. All cases were reviewed for outcomes of interest, including mortality, delayed hypotension, intubation, vasopressors, and various length of stays. And we collected fluid volumes that were administered by bolus in the ER at 1, 3, 6, and 24 hours. All of our models were adjusted for mortality and ED sepsis score, time to antibiotics, obesity, end-stage renal disease or heart failure history, and lactic acid value. We ended up with 4 groups. At the 1 hour group, we had 176 patients, or 17.1%. At 3 hours, 504 patients received the recommended 30 ml per kg amount. At 6 and 24 hours, we had 670 patients and 820 patients, respectively. The median volume at 3 hours in this study was 28.8 mLs per kg, and the median time administered, the median time to reach 30 ml per kg was 3.4 hours. When we look at these discrete time points and the impacts on mortality, at the 1 hour time mark, we find no significance. At the 3 hour time mark, however, we do find a significantly decreased odds of in-hospital mortality, and this trend appeared to continue at the 6 and 24 hour time marks, although that 6 hour time mark did not reach statistical significance. We then aimed to look at time as a continuous variable and to plot this. While this appears to be a curve, there is actually no statistical evidence of curvature. However, the linear portion of this curve, as seen here, is statistically significant with an odds ratio of 1.30. This suggests that the greatest effect is seen at these earlier time points, and that for each hour in delay of IV fluids, mortality increases. It's important to note, however, when we did look at that 1 hour time point specifically, we did not observe any statistically significant findings. We then created dose effect curves at 1, 3, 6, and 24 hour time marks. Only the 3 and the 6 hour time marks were found to be significant. For the 3 hour curve, a plateau effect was seen around 35 to 40 mLs per kg, without any significant decrease in mortality at fluid volumes beyond that. For the 6 hour curve, we see a plateau effect around the 50 to 55 mLs per kg amount. These figures support the current recommendations of that 30 ml per kg amount at 3 hours, and perhaps that window could be extended out to the 6 hour time mark, and ultimately that low volume resuscitation early in the presentation of sepsis may cause harm. Final points, some of the limitations of this study is obviously this is a retrospective single center study. Our cohort also did include both patients with severe sepsis and septic shock. This is a highly heterogeneous study population, and sepsis is of course a highly heterogeneous disease state. And future studies are needed. We likely need a much larger cohort, and we should be ready to evaluate these time points in upcoming prospective trials. Our group found no data to suggest harm with the recommended 30 ml per kg bolus. We do find a benefit at the 3, 6, and 24 hour time points without any benefit seen at the 1 hour time point. Our dose effect curve suggests harm with lower volumes of fluid given early in the resuscitation of patients with sepsis, and ultimately our findings support the current Surviving Sepsis Campaign guidelines and CMS guidelines.